Okay.
We need to start early. Start by 3 or 4.
Good morning, teachers and my dear colleagues. So welcome to today's journal club. And myself, Dr. Lakshmi, will be presenting the first article for today's journal club. And my moderator is Dr. Ramsir. And today's first article is on the topic evaluating the effectiveness of medical therapy in infantile epileptic spasm syndromes due to surgically remediable lesions by Ankita Singh et al. And so this was published in Epilepsia Journal in the year January 2025. So infantile epileptic spasm syndrome is a term proposed to encompass that accommodate two specific syndromes that include the classic Bett syndrome and the infants with epileptic spasms, not fully fulfilling the Bett syndrome criteria, which include the triad of infantile spasms, hips arrhythmia in EEG, and developmental regression. So IESS cases may lack one of the three classical criteria that fulfills the classic Bett syndrome also. So IESS is characterized by, so this is the diagnostic criteria by the ILA 2022. So IESS is characterized by the onset of epileptic spasms between 1 and 24 months, with a peak of 3 and 12 months of age, which are brief contractions of axial muscles, which consist of epileptic spasms consist of brief tonic contractions of axial muscles, and each typically lasting for less than 3 seconds. So which may be a flexor or extensor or mixed phenotype. And EEG is consistent with hips arrhythmia pattern, which is a chaotic, high amplitude, excessive, slowing, multifocal epileptiform discharges. And this may be accompanied by developmental slowing after the spasm onset also. So coming to the pathogenesis of infantile epileptic spasm. So it is multimodal hit theory, which includes interaction between the nerve growth factors, the hypothalamic pituitary adrenal axis, and inflammation. And both the cortical and subcortical interactions are important in the generation of IESs. So in approximately 60 to 80% of cases, an underlying etiology can be determined, and those include acquired structural abnormalities, developmental structural anomalies, and genetic diagnosis. And a significant subgroup of IESS patients harbor surgically remediable epileptogenic lesions on brain MRI, such as focal cortical dysplasia or perinatal stroke. So these are some of the representative images to show the surgical causes of infantile epileptic spasms, which include hypothalamic hamartomas, hemimegalencephaly, focal cortical dysplasias, and hemispheric gliosis. So coming to the treatment of epileptic spasms. So these include both medical management and the surgical management. So the first line or the standard medical management include adrenocorticotropic hormone, vigabatrin, which is irreversible inhibitor of enzyme GABA aminobutyric acid transaminase, and the corticosteroids, which include prednisolone. And surgical management include hemispherectomy or subtotal hemispherectomy, which is often more effective, and lobectomy or multilobar resections, and tuberectomy for focal lesions. So this RCT on the safety and effectiveness of hormonal treatment versus hormonal treatment with vigabatrin for infantile spasm, that is ISIS, which is a multi-center study, showed that hormonal therapy with vigabatrin achieved higher spasm cessation, that is in around 72% versus hormonal therapy alone, that is in 57% within 14 to 42 days, with a significant p-value. So the Child Neurology Society recommends starting first-line medical therapy for IESs within 1 week of diagnosis, with an exception of infants with a surgically remediable lesion. So they may bypass the first-line medical therapy and undergo direct surgery. So even though guidelines or expert recommendations may support early surgical interventions for infants with a newly diagnosed infantile epileptic spasm syndromes, in a real world, the clinical setting, real world clinical settings, it is challenging to rapidly proceed to surgery. So with this brief introduction, coming to the aim of our study is to examine the response to initial medical treatment in patients with IESs harboring a surgically remediable lesion on brain MRI, to evaluate clinical and demographic risk factors for drug resistance in this subgroup, to assess whether failure of a standard therapy predicts subsequent drug resistance in surgically remediable lesional IESs, and to investigate if earlier recognition of drug resistance can facilitate timely surgical referral for improved outcomes. So this is a single center retrospective study. It underwent in the Department of Neurology, Boston Children's Hospital, Massachusetts, USA. Inclusion criteria includes children with IESs diagnosed between 2014 and 2022, identified from the institution's infantile spasm registry and epilepsy surgery database. So presence of a surgically remediable epileptogenic lesion with which are visible on brain MRI were included, and at least 12 months of follow-up was available after diagnosis. So their definition on surgically remediable epileptic syndrome include epilepsy with a non-pathophysiology, drug resistance, and progressive features like developmental delay, making surgery a strong option for seizure freedom. So MRI categories include discrete unilateral lobar lesion, like FCD or other cortical malformations, unihemispheric multilobar or diffuse lesion, like hemimegalencephaly, MCA infarction, Sturge-Weber syndrome, bilateral asymmetric lesions with predominant unilateral involvement and clinical or EEG lateralization, and for bilateral asymmetric causes, surgery can be chosen when a lower risk for additional deficit is expected. For example, existing functional loss. So exclusion criteria included inadequate clinical or treatment details regarding IESs. The patients considered solely for any palliative procedures like corpus callosotomy or vagal nerve stimulation, and the diagnosis of tuberous sclerosis complex due to prevent trial enrollment, which happened in the same the corresponding period. So they have defined what is relapse and what is response. So a short-term response is the cessation of epileptic spasms and resolution of hips arrhythmia between day 14 and 42 after starting standard therapy. And a relapse is the recurrence of epileptic spasms or hips arrhythmia following an initial response. And a drug responsive or drug resistant groups were so the patients were classified into a drug responsive and a drug resistant group. So a drug responsive group is includes patients who showed short-term response to initial standard therapy, that is 1 to 2 standard agents, and remained free of epileptic spasms and other seizures at the last follow-up. And all patients in this category were managed with medical therapy alone. So the drug-resistant group included patients with a patients with non-responsive to initial standard therapy, failure of 2 agents, or exceptionally 1 agent if second was not tried. Patient with an initial response but later epileptic spasm relapse, not corresponding to standard therapy. Patients with focal seizures unresponsive to medical therapy, and patients who received only non-standard therapy for IESS were also considered drug resistant if epileptic spasm or focal seizures persisted despite therapy. So the primary outcome measured include the short-term response to the first and the second standard therapy in children with surgically remediable lesional IESS. And the secondary outcome measured include identification of risk factors for drug resistance and estimation of probability of progression to drug-resistant epilepsy stratified by response to the first standard therapy. So group comparison were done with chi-square test for categorical variables and student t-test for continuous variable. And the risk factor analysis was done using a multifactorial, multivariate logistic regression. And p-value of less than 0.05 is considered significant. The Kaplan-Meier survival analysis is used to estimate and visualize the survival function and to estimate probability of remaining drug resistance free. Survival time from IESS diagnosis to drug resistance in case of a resistance group or last follow-up in case of responsive group were calculated. And the date of resistance, that is failure of standard therapy, initial or after ES relapse or the resurgence of drug resistance focal seizure was also noted. So they identified 61 patients with surgically remediable IESs meeting the inclusion criteria. And this included 57% of females, and the median age of IES's onset was 5 months, and median follow-up duration was 52 months. So seizures prior to IES's onset was also noted, and this included 47%, that is 28 patients of the total cohort. And neonatal seizures were present in 6 patients. Post-neonatal seizures were present in 15 patients. Both neonatal and post-neonatal seizures were present in 7 patients. But the seizure type per se was not described. So coming to the EEG and MRI findings. So the initial EEG finding was available for 59 patients out of 61. This included focal features in 72% and hips arrhythmia pattern in 56%. And the MRI lesions were seen, that is congenital structural lesions were seen in 61%. And an acquired structural lesion was present in 39% of patients. And 85% patients had a unilateral lesion, out of which 31% had lobar, 48% had multilobar, and 21% had hemispheric lesion. And a bilateral asymmetric lesions were seen in 15%. So the specific etiology included FCD, which was present in 27, which is the most common etiology. Perinatal stroke was present in 13%. Venous infarct and hemorrhages was present in 6%. Polymicrographia in 5. Aicardi syndrome in 2. Hemimegalencephaly in 2. And infectious causes in 3. And neurofibromatosis 1 was present in 1. And low-grade glioma in 1. And Sturge-Weber in 1 patient. So coming to the response to the standard therapy. So of a total 412 patients, 412 total IESS patients were screened, and out of which 332 had no surgically remediable lesions on MRI, and 19 patients had inadequate follow-up. So excluding all these patients, of the we had 61 patients, and of the 61 patients, standard therapy was used in 95%, that is 58 patients. And the lead time to the first standard therapy was a median of 15 days. So among the 37 responders to the standard therapy course, 15 were classified as sustained responder, which is having achieved a seizure freedom following the initial standard therapy course and maintaining it until the last follow-up. And among the 37 patients, 22 patients had an epilepsy relapse, and 14 patients relapsed with epileptic spasms, and 8 patients relapsed with focal seizures. So out of the 14 patients, 12 received a second line agent, and out of the 12 patients, 5 were drug responsive, and the rest, that is 9, became a resistant. And out of the 8 patients with focal seizure, 4 became drug responsive and 4 became drug resistant. And all the non-responsive patients were given, that is 21 of the non-responsive patients were given the second line, and out of which 1 had a drug responsive epileptic spasm, and the rest 20 had a drug resistant epileptic spasm. So a total of 25 patients were drug responsive, which were managed under like medically, and 36 patients had a drug resistant epilepsy, so which underwent surgery. So 34 underwent surgery, and after the first surgery, they attained an Engel class 1 of 55.9%, attained a Engel class 1 after first surgery, and 20.6% attained Engel class 1 after a repeat surgery. That is, so a total of 76.5% attained Engel at final, Engel 1 at final follow-up. So 2 patients did not underwent surgery because both had Aicardi syndrome. So coming to the seizure outcome on follow-up, so patients were followed up. So that is, they were classed, that is grouped as patients with sustained response, patients with relapse, but was drug responsive, patients with relapse which were drug resistant, and the patients with non-responsive, which were non-responders. So in the group of sustained response, 53 patients had hypsarrhythmia, 67% had acquired etiology, and 73% had extensive MRI abnormality. And in the patients in the group with relapse with drug responsive, who are drug responsive, 56 patients had hypsarrhythmia, 22% had acquired etiology, 33% had extensive MRI abnormality. And in the drug resistant relapse group, 62% had hypsarrhythmia, 15% had acquired etiology, 78% had extensive MRI abnormality. And in the drug non-responders, 62% had hypsarrhythmia, 33% had acquired etiology, and 86% had extensive MRI abnormality. And out of the 61, that is out of the 58 patients, hypsarrhythmia or modified hypsarrhythmia was seen in 34 patients, and multifocal epileptiform activity was seen in 24 patients. And acquired etiology was seen in 21, and congenital etiology was seen in 37 patients. And extensive MRI abnormality was seen in 42 patients, and a lobar MRI abnormality was seen in 16 patients. So a Kaplan-Meier survival curve, showed the freedom from drug resistance were plotted, and a cumulative survival without drug resistance at 2 months, 6, 12, 24, and 36 months were calculated, and this was found to be 57%, 52%, 47%, 43%, and 38% respectively. And a comparison of characteristics between the drug resistant and the drug responsive group were done, which revealed that extensive MRI abnormalities, which included congenital structural lesions and a younger age of IESS onset, were associated with drug resistance. But sex, pre-existent seizures, the focal seizures on EEG, and lead time to first standard treatment did not differ between the two groups. So a multivariate analysis, logistic regression analysis confirmed that congenital structural abnormality, then extensive MRI abnormality increased the odds of drug resistance. And the multivariate logistic analysis is used to predict a binary outcome by considering multiple independent variables simultaneously. So coming to the details on epilepsy surgery. So out of the 36 drug-resistant group, surgery was performed in 34 patients, and 2 patients were not operated because of 2 had IGAD syndrome as well as parental refusal. And the drug resistance, that is the median time between the drug resistance to surgery was 7.5 months, and the median interval between the IESS onset to surgery was 17.5 months. So the median age at surgery was 22.5 months, and a post-surgery follow-up of 31.5 months were also done. So the surgical procedures were lobectomy or lesionectomy that happened in 41%, with a multilobar resection in 12%, hemispherectomy in 47%, and a single stage without invasive monitoring happened in 91%. And a callosotomy prior to disconnection was done in 2 patients. And reoperations happened in 21%, which included functional hemispherectomy, completion of an anatomic hemispherectomy, lobar disconnection, multilobar resection, and laser ablation. And the histopathology showed MCD as the most common etiology. Then gliosis was seen in 23%. Low-grade neuroepithelial tumors were seen in 3%. Leptomeningeal angiomatosis with microcalcifications were seen in 3%. And histopathology was negative in 9% and non-available in 15%. So although 2/3 of patients, that is 64 patients, achieved a short-term electroclinical remission remission, relapses either as epileptic spasms or other seizure types occurred frequently in 59%. And the likelihood of remaining drug responsive decreased over time. That is from 57% at 2 months and 38% in 3 years. So the structural abnormalities in MRI and the early onset, early IESS onset were predictors of high drug resistance. So the other risk factors for drug resistance include MRI abnormalities like extensive lesions, congenital structural abnormality in the MRI, and the failure of first-line therapy were strong independent predictors for drug resistance. So relapse and limited long-term drug efficacy, then multilobar or hemispheric pathologies were common. And so this reinforces the role of early surgery in selected patients. So the post-surgical data showed that 76%, 76.5% achieved an Engel class 1 outcome at a median of 2.6 years follow-up. And the seizure freedom after surgery ranged widely, that is from 45 to 90%, with hemispherectomy outcomes especially favorable. And incomplete lesion resection, bilateral or genetic abnormality in congenital structural conditions may contribute to, so they were the reasons for early surgical failure, and that happened in approximately 25%, that is a quarter of patients. And so shorter epilepsy duration before surgery correlates with a better seizure and cognitive outcomes. And they also found that a brief delay, that is as little as 1 week in starting standard therapy, can negatively impact the neurodevelopment in patients with IESs. So early failure of standard therapy strongly predicts drug resistance in lesional IESs. And hence, a surgical evaluation of after failure of 1 to 2 appropriate anti-seizure medication trials is essential. So these are some of the literatures. And this study, which studied the factors influencing the response of patients with IESS to ACTH as repeated first-line therapy, showed that the response to sequential ACTH was more likely if patient had an initial short-term response and a younger age of treatment, and a short-term response to initial first-line favored a better outcome. And this predictive model for initial response to first-line treatment in children with epileptic spasms showed that approximately 40% initial efficacy for first-line medical therapies are common. And and this also suggests that an early and effective control of spasm is critical for better long-term outcomes. So early surgery. So this study on the surgical treatment for refractory epileptic spasm showed that early surgery within 3 years of seizure onset is associated with significantly better seizure outcome, with up to 88% achieving seizure freedom if operated early. And they also, so this is another study that looked into the outcomes following receptive and disconnective strategies in treatment of epileptic spasms. So they also found, this study also found that around 67 to 68% of patients undergoing resective surgery become spasm free, and early surgical intervention improves the seizure and the developmental outcomes. So now coming to the limitations of the study. So it is relatively small patient cohort, leading to a low statistical power, and it has a retrospective design subject to biases. And the possible selection bias towards more severe cases seen at a tertiary epilepsy center limits its applicability to a broader population. And they also did not evaluate the response to combination therapies, and they did not assess developmental outcomes in this 61 children. And also, they have focused only on patients with MRI visible lesions at IESS onset, excluding the potential surgical candidates without an MRI lesions, but other focal abnormalities like in PET, EEG, or MET. So strength of the study includes, it provides a detailed data on the response to the first standard therapies. And it offers important clinical insights on the risk of drug resistance and seizure relapse in lesional IESS. And it adds evidence on predictive value of standard therapy response, and enables better understanding of MRI lesion burden and structural abnormalities as major correlates of drug resistance and surgical outcomes. So it also contributes real-world data from a specialized tertiary center with a comprehensive imaging aiding the clinical decision making, and it highlights the practical barriers and biological complexities affecting the timing of surgery in infants, and also support consensus recommendation for rapid treatment initiation and surgery considerations in patients with lesional IESS. So critical appraisal. So this major study strength include, so the study focuses on a clearly defined subset, that is the patients with IESS and who are surgically, IESS with surgically remediable lesions, and the multimodal assessment, that is, it combines the clinical neuroimaging, EEG, and the surgical outcome data. And the initial response to medical therapy is common, but relapse rates are high. So that is, there is only a transient benefit, and the drug resistance is frequent, and the risk is increased in the congenital and extensive MRI lesions, but reduced in later onset IESS. So this also provides the data on the surgery that shows higher seizure freedom rates and better developmental outcome in drug resistant patients. So the retrospective study, single center study with the non-randomization and heterogeneity in the therapy protocols are the major methodological limitations. So after this study, we can recommend that early recognition and surgical evaluation are key for optimal outcomes in IESS with structural lesions. And studies should include standardized protocols prospective design and comparative outcome groups. Thank you. Thank you. Jyoti.
I think Dr. Lakshmi has covered this topic comprehensively. I'll just make a few points with regard to what has not been touched upon from the perspective of early surgery patients with epileptic encephalopathies such as infantile epileptic spasm syndrome, or what was previously referred to as West syndrome. What you must understand is that once you identify a symptomatic etiology, whether it is structural, whether it is genetic, metabolic, or post-infectious etiology, the likelihood of relapse to or lack of response to standard therapy is higher in this group of patients. So as shown in this particular series, nearly 60%, more than 60% of patients relapsed after initiation of standard therapy, which is either steroids, that is ACTH or prednisolone, along with vigabatrin in combination or as monotherapy alone. And subsequent trials of further anti-seizure medications, whether you add a newer anti-seizure medication, is unlikely to be completely successful, although you have a small subset of patients who might be responders on the long-term basis. But the main concern with regard to this study is the absence of clear developmental data as to what are the developmental quotients which were at baseline and at follow-up post-surgery in this group of patients, which is one limitation of this study and is considered as a major limitation. As mentioned by Dr. Lakshmi, the series from Detroit by Dr. Harry Chugani, as well as certain systematic reviews, have indicated that developmental quotients or the trajectory of development is better in those children who undergo surgery early, once you identify that they are not responders to standard therapy. The other aspect you must remember is that once you treat children with West syndrome with corticosteroids or vigabatrin, the likelihood of them developing focal seizures on follow-up because of that underlying structural etiology is a realistic possibility. And the other aspect is that the EEG might also start exhibiting focal abnormalities. So what you initially interpreted as hypserhythmia might actually narrow down to focal abnormality once you treat with the first-line therapies. So that is why close follow-up of these children is extremely essential, and referral for early surgical intervention once you realize that they are not long-term responders to standard first-line therapy. So these are the most important take-homes. The aspect which is not answered is whether early surgery before initiation of the standard first-line therapy is pertinent or not in this scenario. That is, suppose you have a child who's developed West syndrome. Within 1 week of onset, you realize that the patient has a structural etiology, and whether those patients should undergo surgery early. That is a matter of debate and can only be proven by randomized studies. But this being a rare, West syndrome is not as common as other focal epilepsies. This being a rare disorder, and the fact that you require developmental data, and the fact that these lesions, because they are very extensive, involve eloquent areas. And if you have to subject the child to extensive hemispheric procedures such as disconnective hemispherotomy or multilobar resections or posterior quadrant disconnections, you have to understand that the risk of deficit is there. So, which is why probably first-line therapy may continue to remain in future over and above surgical therapy. But it is a matter of time wherein we have to get into this debate about surgical versus medical therapy in this group of patients. It's not that 100% of these patients are going to be drug refractory. You could say that probably 2/3 of the patients are going to be refractory. But this data can only be answered. This data can only be addressed with the help of a long-term randomized control study. Thank you.
Good morning. Today I will be presenting about clinical radiological presentation and natural history of heterogenic cerebral amyloid angiopathy. And the moderator is Dr. Sajith sir, and the presenter is myself, Dr. Jothivannan. What is cerebral amyloid angiopathy? It is the accumulation of amyloid beta particle in leptomeninges of small to medium-sized cerebral vessels. In the vessels, it will be getting accumulated in mostly in the media and basement membranes. It commonly presents as lobar hemorrhage in the elderly. And if in comparison, all the Alzheimer patients will have 84 to 96% cerebral amyloid angiopathy, whereas cerebral amyloid angiopathy patients, 40% have Alzheimer's disease. What is the pathogenesis? Amyloid precursor protein undergoes two pathways. Alpha secretase pathway is the normal pathway where we will get P3 molecule, which is a non-toxic molecule. Whereas any abnormality happens in the amyloid precursor protein will lead to undergo beta secretase pathway and gamma secretase pathway will lead to production of amyloid beta, and which can lead to oligomerization and formation of toxic molecules. What is the pathogenesis? Once the amyloid precursor protein is undergone degradation by beta and gamma secretase, we have mainly amyloid beta polypeptides. They range from 38 to 43, but our area of interest is 42 and 40. What is the, because 42 is the main peptide in Alzheimer's disease, whereas 40 is the main peptide in cerebral amyloid angiopathy. Even though 40, the other peptides also contribute in amyloid and Alzheimer's disease, the main molecule is 42. 40 also can be seen in Alzheimer's disease. Once these are produced, it can undergo degradation by metallopeptidase enzymes or by astrocytes or by lymphatic drainage through LDL receptor related transportation. What is the natural history of a cerebral amyloid angiopathy? Stage 1 is where the deposition starts. It's usually 30 years before the symptom onset of a bleed. So first one is a stage 1 where amyloid deposition starts and there is no clinical symptoms. Second is where the deposition increases and the vessel loses reactivity. In any process, the vessels usually undergo vasodilation or vasoconstriction. These both are lost in these patients. So in 3, the more the deposition happens, the patients will start to have ischemic symptoms in form of non-hemorrhagic injuries like white matter hyperintensities, cognitive impairment. This occurs 10 to 15 years before the bleeding manifestations, where stage 4 is hemorrhagic lesions, which can be symptomatic intracerebral hemorrhage, convexity hemorrhage, subarachnoid hemorrhage, or transient focal neurological episodes. So if you follow the blue, which is amyloid precursor protein, which this is the normal pathway, which becomes soluble amyloid beta particle, which is cleared through the perivascular space. If a abnormal beta secretase pathway acts on this, we will get abnormal production of alpha A beta 40, which can lead to accumulation and cause cerebral amyloid angiopathy. And this will result in development of cerebral amyloid angiopathy and destruction of the vessel wall. So why the treatment like, and they both Alzheimer's disease and cerebral amyloid angiopathy is due to increase in the cerebral amyloid. But why anti-amyloid therapies are not used in cerebral amyloid angiopathy? It is because of this study, which has shown patients who are given anti-amyloid beta immunization with Alzheimer's disease who had parenchymal A beta 42. After giving the disease, they started to have increase in the vascular area. Already these patients have increased vascular A beta 40 in the vessels, and increase in the load further contributes to the worsening of the disease. And amyloid beta, in these patients, amyloid beta is already in the vessels, and anti-amyloid therapy will act on these vessels, and these patients will undergo inflammation and inflammatory situations. So cerebral amyloid angiopathy will have Boston criteria, which is revised, which is used is Boston 2.0, which has clinical presentation. Here the age is more than 50 because of the clinical presentation. This is a prolonged course. Patients will have included or usually age more than 50 and will have clinical presentations and MRI features. MRI features are divided into hemorrhagic features and white matter features. Hemorrhagic markers, we have lobar bleed, lobar microbleed, cerebral cortical superficial cirrhosis, and convexity subarachnoid hemorrhage. In white matters, we have increased perivascular spaces in centrum of semi-ovale and multispot pattern of white matter hyperintensities. What is iatrogenic cerebral amyloid angiopathy? It is a newly recognized term which is due to transmission of amyloid beta seeds through medical procedure. Usually linked are transplanted human dura mater, embolization of lyophilized dura mater, cadaveric pituitary growth hormone, and the mechanism is alpha A beta seeds act as prions. During the procedure, there is a transmission of A beta seeds, which go and alter the amyloid precursor protein and starts to produce the misfolding and propagation of abnormal proteins, which can accumulate and cause the iatrogenic or cerebral amyloid angiopathy. The particular amyloid beta like 42, 40 is not clearly mentioned, but they have mentioned only as amyloid beta peptides aggregates. The predominance is not still hypothesized. So this all started when 2022, there was the paper which was published in the BMJ, which is the iatrogenic cerebral amyloid angiopathy, an emerging clinical phenomenon. In that, they have described what is iatrogenic amyloid angiopathy based on 23 case clinical case patients, and they have proposed the criteria to diagnose a patient with iatrogenic amyloid angiopathy. What they basically did is they took the Boston criteria and added the exposure criteria, exposure of neurosurgery, and gave this Queen Square criteria. Coming to the topic, the aim of the study is to characterize the clinical features and neuroimaging patterns and long-term outcomes in patients with iatrogenic cerebral amyloid angiopathy. The study design, it is a pooled multi-center cohort study, and data is like collected by systemic literature where more patients had case series. Any case series which had more than 5 patients diagnosed with iatrogenic cerebral amyloid angiopathy was included in the study, and the time limit for the cutoff for the literature search was 31 December 2023. The inclusion criteria is patients who had modified Queen Square criteria for probable or possible iatrogenic cerebral amyloid angiopathy and need at least one MRI for inclusion. This is the modified Queen Square criteria for iatrogenic cerebral amyloidopathy. In that, modification was done in these two highlighted areas. Okay. Where in original Queen Square criteria, clinical and radiological features were there. Here they made it to clinical and or radiological features. And in the original criteria, they didn't include the deep hemorrhages, but in this, they included the deep hemorrhages as part of the criteria. Otherwise, it is almost similar to the Boston criteria, except for the new age. Age is less than 55 and more than 55. Method is case reports were collected from every center based on demographics, exposure history, clinical presentation, genetics, MRIs, and follow-up was individualized. Often annual clinical and MRI varied between different centers. And neuroimaging analysis, it was done by a neurovascular specialist and a senior neuroradiologist. MRI sequences were seen. Markers were assessed based on microbleed, superficial cirrhosis, white matter hypertension, and standard scales were used. And laterality was assessed by if ratios more than 1.5, it is ipsilateral dominant, or less than 0.7, it is 6.7, it is contralateral dominant. If it is in between them, it is neutral. The baseline characteristics, the male sex was predominantly there in the probable, which was 76.9. The cranial surgery, most of the patients had undergone cranial surgeries, which is 70.6% in total. And symptomatic presentation is most common is intracerebral bleed. And other investigations, it's a dura usage, dural patch of unknown type, and missing information. Other thing, exposure event is cranial surgery, spinal surgery, head and neck embolization. This I will explain later. So total 51 patients were included in the study. 51 met the criteria of probable iatrogenic amyloidopathy, and 49 met the criteria for possible. The predominantly were males, which was 68.6%, and median age of symptom onset was 48 years. And median latency to exposure is 38 years. Most common exposure is cranial neurosurgery, which is 70.6%, followed by spinal surgery, 21.6%, then head and neck embolization and confirmed cadaveric use, dura use. Biomarker 76.5% had genetic testing. Out of that, 52.59% only had evidence of CNS amyloid beta pathology by one or more modalities, that is by PET, CSF, or biopsy. The results of the study, the most common in clinical findings, the initial symptom, most common presentation is intracerebral hemorrhage, which was seen in 45.1%. And in follow-up events, the most common is a symptomatic intracerebral hemorrhage. It is seen in 43 patients. And in clinical outcomes, the symptomatic ICH recurrence was more, almost 50% during follow-up. And median cortical microbleed count was tripled over the follow-up. The follow-up period is 3 years, which has been done in the study. And around asymptomatic hemorrhages were frequent and mortality was low in the clinical outcomes. So if we MRI outcomes, we can divide into one is like bleeding manifestations and white matter hyperintensities. In bleeding manifestations, all the parameters increased. The lobar microbleeds in the baseline was 16%, increased in 53%. Deep microbleeds from 19.6 to 44%. Cortical superficial cirrhosis 68 to 88. And disseminated was 47 to 73. All the hemorrhagic parameters increased in this group. White matter and diseases like non-hemorrhagic markers, we have white matter hyperintensities. There was moderate increase. But multi-spot pattern, we have 11.8 to 20. It was slightly increased. And the pattern here is perivascular spaces in centrum semioval was more increased compared to the non-increase in the basal ganglia, which was suggestive of more of amyloid involvement. And in additional MRI findings, white matter findings increased and multi-spot pattern increase, which was suggesting a diffuse small vessel involvement. And perivascular space in the centrum semioval, which has increased, which was like amyloid-related distribution. And 27.5% had edema and sulcal hyperintensities, which indicated episodes of inflammation. And there were asymptomatic ICH and laterality. Ipsilateral dominance of cortical microbleeds cirrhosis was patient, most commonly seen in unilateral surgery. Patients who underwent unilateral surgeries supports localized amyloid beta deposition. This laterality, out of all the patients, only 31 patients underwent supratentorial unilateral surgery. In that patient alone, laterality was assessed. Patients who underwent spinal surgery, laterality could not be established. So this is the how images progress. This is the first image where the progression of cerebral amyloid angiopathy. This is a 40-year-old male who has underwent, he had a trauma in the childhood and underwent a cadaveric dura transplant with history of occipital craniotomy. This is the, he presented initially with this, and this MRI was taken, which was showing a bleed and bilateral hyperintensities and small lobar bleeds, and other areas were normal. He was 2 years later, the same person who was presented with large bleed on the other side and hyperintensities and multiple lobar bleeds, microbleeds. And this is to show the laterality of the heterogenic cerebral amyloid angiopathy. This patient underwent the procedure on the left side, and over the years he started to have manifestations and increased hemorrhagic markers on the same side compared to the other side. So discussion, the hemorrhagic progression, there was a marked increase in the hemorrhagic markers over the 3 years, which indicates a sustained active vasculopathic process, and there is a many asymptomatic small intracranial ICH were observed during the study, which underscores the clinically silent disease activity. In the deep hemorrhagic lesions, most of the patients had deep hemorrhagic lesions in this group compared to the exclusion of deep hemorrhages in Boston criteria. Boston criteria doesn't include deep hemorrhages as a part of criteria. But here, most of the patients had deep hemorrhagic lesions, and these are likely to reflect pathology is more due to heterogenic amyloidopathy rather than the hypertensive arteriosclerosis because of her younger age and few vascular risk factors. Lateralization, unilateral supratentorial exposure and progression of hemorrhagic markers often lateralize to the same hemisphere where the patients have undergone the surgery, which supports propagation model like prion kinetics, like local vulnerability near the inoculation site, despite evidence of more widespread dissemination. And the patients also had transient inflammations, which were common in these patients compared to the sporadic CAA. And clinical trajectory, most of the patients had high recurrence rates, but surprisingly, the mortality was low despite even the high increase of recurrence and bleed. And pathophysiological interpretation is this was like a prion model where early propagation followed by toxicity phase manifesting as vasculopathy and hemorrhage. So, in conclusion, heterogenic cerebral amyloid angiopathy exhibits a unique and aggressive neuroimage profile. It is very rapid and aggressive because in natural progression from the symptom onset to the bleed, we have 10 to 15 years. Here we had patients coming within 2 to 3 years of the first clinical presentation. Second is it is mostly focal ipsilateral spread of hemorrhagic markers, and patients had deep cortical microbleeds and frequent inflammatory changes and large and frequent asymptomatic intracranial ICH. So this study says there is a distinct phenotype of cerebral amyloid angiopathy, which has its own natural history, imaging evolution, and diagnostic challenges. The strength of the study is it is the largest multicenter cohort in this patients till date, and systemic collection of individual level data with longitudinal MRI studies and centralized MRI scales were used. And it provides distinctive imaging profile, which differentiates between heterogenic versus sporadic condition. Limitations were modest sample size, selection bias, varying image protocols, inter-rater reliability is not there, no blinding, and there is no statistical comparison between the groups, incomplete exposure of documentation, 39.2 patients didn't have surgical records, and lack of neuropathological correlation.
Study. Looked at the critical profile of where branches develop. So they consider pairing characteristics, more definition, more diagnosis, and then more historical control that non-iatrogenic get to do how they do, because you have stated them very aggressive. Others have very aggressive to compare with the non-iatrogenic amyloid.
No, sir, they haven't directly compared it with the they haven't directly compared with the patients, sir. They have proposed like usually that clinical progression will take a years, but this is like rapidly progressing, like that only they have mentioned.
There is that speak.
No, sir, no.
So very similar to open. So at diagnosis, how the two groups are posterity comparison. Not I had to get some but I had to get at diagnosis. Was there any difference? The patterns neither white variation, so it could be
At baseline, age of onset was more younger in this patient, sir. They presented usually 1 decade earlier than this, what usually this sporadic patients used to present. No, sir. Yes, sir.
survival curves and what can even coming across. You have
I have no comment, sir.
create your own tolerance. So do you think that the historical control that non-iapotelic
Yes, sir.
your information for the progression for the non-iapotelic research? Because you have presented the iapotelic, what is your understanding with the progression?
They tend to have a older age profile and slow progression, sir. And
Starts like a very focal localized and can be spread.
yes, sir.
So with regard to the cognitive functionality and diagnosis, can there be a difference between these? Non-iapotelic problems in generalized pattern. Here you have a very localized ones which are less population. So
It could be different.
so these are things that you typically look in the papers and it's what it is in myself. It should not be like just wait for something and then just take care of it. It's the idea that physical ability of non-iapotelic and the information we have in the survival concern. And then you look into the unity and it's what we are. Data on trauma it's pure trauma and
Yeah, in this patient's most common APO is 3, sir. 3 was mentioned. This patient didn't have particular trauma history, sir. No, sir.